And today, I'll briefly talk about the Doppler diagnosis, why we can use Doppler in the detection of Nutcracker phenomenon and diagnosis of Nutcracker syndrome. Uh, this is a condition we traditionally diagnosed with invasive venous catheterization and pressure measurement. And when this pressure, the gradient is less than 1 millimeter mercury, we consider it's a normal. And when this pressure gradient is more than 3 millimeter mercury, we consider it's abnormal, and we can make a diagnosis of Nutcracker phenomenon using this invasive technique. At the time, we usually do this invasive procedure in patients with gross hematuria. But nowadays, we can use Doppler ultrasound, grayscale ultrasound. We can see the compression on image, and with color Doppler ultrasound, we can see the hemodynamics in these vessels, and slow flow here and fast flow here. And we can measure actual flow velocity in these fast flow areas. And in this patient, it was higher than 200 centimeter per second. And we do because this Doppler ultrasound is very easy to perform, we do this procedure in a lot of suspicious patients, like patients with have a incident microscopic hematuria, proteinuria, and some unusual pain in abdomen and flank areas. And we can detect a lot of Nutcracker patients with this Doppler ultrasound. And in the initial stage of using ultrasound in detection of Nutcracker phenomenon, we used this anatomic parameters like anterior-posterior diameter of the left renal vein in this hilar area and in this aortomesenteric area, and compare them. And here are data from two studies, and this is a diameter of left renal vein at aortomesenteric area in millimeter, and it's not very different. And in this hilar area and this one, and the ratio is like this one. And this is in this another study, and also similar in aortomesenteric areas, and a little bit different in the hilar areas, and the ratio is a little different. So this there are significant measuring error in this very narrow portion, and there are too much overlap between the Nutcracker and control group. So it is difficult to use this the anatomic parameter in the diagnosis of Nutcracker phenomena. And here are two old papers saying that this distended left renal vein is a normal variant. And these two papers saying the same thing. And when these two papers said that when hilar left renal vein has a diameter 50% or more greater than the diameter of the aortomesenteric left renal vein, in this first paper, it was 74% of the patient population had showed this finding. And in the second paper, the 50% showed that finding. So just the distended left renal vein itself is we cannot say it's abnormal. It's just a normal variant. I think because it's a natural normal compression of the left renal vein in aortomesenteric area. And another point we tried to use was the aortomesenteric angle. Like in the sagittal ultrasound, we can easily measure this angle, and also sagittal plane CT scan, we can measure this angle easily. And usually in normally, its angle is about the rectangular, about 90 degrees. And when this angle is narrow, we can suspect nutcracker phenomenon. But this the also it's easy to measure, but there's also too much overlap between the nutcracker and control group. So it's also not easy to use this aortomesenteric angle in differentiation between the nutcracker and the control group. And so in about 30 years ago, uh, I thought that we can use Doppler velocity in differentiation in detection of nutcracker phenomenon using Doppler ultrasound. And we had a study in 16 nutcracker patients and 18 controls. We compared the velocity in this hilar left renal vein and aortomesenteric left renal vein. And these are data. And in nutcracker syndrome patients, here the nutcracker syndrome patients, we confirm the nutcracker using the invasive, the venous catheterization and pressure measurement, and confirmed the pressure gradient higher than 3 millimeter mercury. In this nutcracker patient group, the velocity at aortomesenteric area was significantly different from the control patients, average 110 in nutcracker group and around 50 in control group. In this highlight area, it was not so different, around between 10 and 20. And if we use the ratio, it was significantly different. So this was a study I have done in an adult group, and in the same hospital, my hospital, in Children's Hospital, they did a very similar study in children group, and they showed a similar difference of peak flow velocity in aortomesenteric and the hilar area, and similar difference in this velocity ratios. So in those two studies, we had a conclusion that, oh yes, we can use Doppler ultrasound in differentiation, in detection of nutcracker patient. And so from that point, from that background, we did a lot of studies in suspected nutcracker patients using Doppler. So the summary is because there is a normal subtle compression in aortomesenteric areas, the velocity in this hilar left renal vein and in this aortomesenteric left renal vein is naturally different. In normal group is in hilar left renal vein, the velocity is around 10 to 20. In nutcracker in normal group it is 10 to 20, and in this aortomesenteric area in normal group it was around 40 to 50. So when this aortomesenteric velocity is twice this value, we can consider as probably it's abnormal. So if it is higher than 80 but lower than 100, we usually consider it's an equivocal nutcracker phenomenon. And when it is higher than 100 centimeters per second, we consider it's a abnormal velocity, and we consider that this patient has nutcracker phenomenon. And if this patient had the symptoms like hematuria, proteinuria, or left flank pain, or other symptoms, otherwise the unexplainable symptoms, we make a diagnosis of nutcracker syndrome. So 100 centimeters per second is a very simple criteria, and now we use this simple criteria in detection of nutcracker patient in our usual the daily Doppler ultrasound examination. So I will show you some examples. This is the old man, asymptomatic man, And this is a grayscale ultrasound. The aorta, superior ventricular artery, and the left renal vein is coursing this way. And in color Doppler ultrasound, this red color means that flow in this direction, and this blue color means the flow in this direction. We can see a little bit brighter the color here, but in this spectral Doppler ultrasound, this is the cycle of the Doppler spectral changes during the respiratory cycle. Usually in inspiration is a little bit lower, and in expiration is a little bit higher, and the maximum was 74 in this patient. So this patient's the velocity data shows that this is a normal subtle compression, and this is not a finding of nutcracker phenomenon. So this is an example of normal Doppler ultrasound findings of the left renal vein. This is a young woman, gross hematuria, and definitely abnormal aorta, superior ventricular artery, and dilated left renal vein, and narrowed aortomesenteric left renal vein, and color Doppler, this red color here, and this is an intermittent bright color in this left renal vein, and this anterior vein is the splenic vein and portal vein. So we should not confuse with this vessel. This left renal vein, it shows the intermittent high velocity flow here, and the spectral Doppler ultrasound shows that velocity was 138 maximum. So in this patient with gross hematuria, there was no other cause of hematuria in this patient, and definite nutcracker phenomenon was there, and we can make a diagnosis nutcracker syndrome in this patient. Then one question we might have is this 100 centimeter per second criteria is equivalent to this 3 millimeter mercury pressure gradient data? We can reliably use this velocity data instead of this pressure data in detection of nutcracker phenomenon. And theoretically, it's possible because of the very famous Bernoulli principle. Dr. Daniel Bernoulli, the Swiss mathematician and physicist, said this theory of principle of continuity. It means that the relation between the pressure and velocity and the elevation height in this the flow system, and is because of our body is we can consider there is no height difference in our body, so we can neglect this height, and also we can neglect this the blood density, and we can neglect the gravity acceleration, and we can cancel this one, and the equation is like we can simplify this equation, and from this equation the pressure gradient is we can measure it theoretically by using the two velocity data, one in aortomesenteric and the other in hilar left renal vein area. I said usually in hilar area is around the 10 to 20, and if we fix this 20 centimeter per second in hilar left renal vein velocity, and in normal it is usually around 40 to 50. So if we use this 40 and 20, this data in this equation, the theoretical pressure gradient is 0.48 millimeter mercury. And we said that between 80 and 100, I said that it's equivocal nutcracker. And if we use the 80 centimeter per second data, it's a pressure gradient 2.39. 100 centimeter per second is a pressure gradient 30.81. 150 is 8.79. 200 centimeter per second, 15. And 300 centimeter per second is around 35. And so I think the 100 centimeter per second theoretical pressure gradient is 3.81 is very important. The background that we can use this 100 centimeter per second velocity data instead of this pressure gradient data using the Doppler ultrasound. So, I think that we can, when we are doing Doppler ultrasound, if we measure the velocity accurately, we can expect the pressure gradient in those patients. But in our body, because of a lot of collaterals, just a theoretical background. In reality, it should be different, but theoretically, it's possible we can use this velocity data instead of the invasive pressure measurement. This is a young woman proteinuria and the grayscale ultrasound, color Doppler ultrasound. This is a highlight area, the spectral Doppler around 20 centimeter per second. This aorto mesenteric area around 150 centimeter per second. Then theoretically, the pressure gradient may be around 9 millimeter mercury. So another patient, this is a young woman proteinuria. Similarly, we can see the very sluggish flow in this dilated hilar left renal vein and the very fast flow here, aorto mesenteric left renal vein, and velocity was 182. Theoretical pressure gradient was 12 millimeter mercury. Young woman microhematuria proteinuria, and similarly, the nutcracker phenomenon we can see at grayscale, we can see at color Doppler, and measure the pressure. The velocity was very high, higher than 300, and probably the pressure gradient will be very high, the theoretically 35 millimeter mercury.